extubation readiness criteria that you need to look into. Okay, so obviously, yes, the conclusion of your SBT, what happens to the gas exchange. So when I say ABG, obviously I had already told you we need to have a reasonably good PCO2, good PaO2, PF ratios, all of those, the endpoints of SBT. But definitely there is a lot more than you need to see. Okay, one, the patient needs to be reasonably awake enough, because if say the reason for intubation was neurological, somebody who is deeply comatose, who is not awake. Okay, you don't want to be extubating them because the primary problem is not a cardiovascular or a respiratory illness, so they will obviously pass their SBT. But the issue here, or the indication for intubation, has rather been need for airway protection. Okay, so you might succeed in an SBT. These are not even patients which qualify for an SBT, and you're not talking about extubation where there is a need for airway protection. Okay, so obviously you need to have a certain amount of wakefulness where they can take care of their airway, where they should be able to cough out, they should be able to handle their airway secretions. Okay, and you should make sure that the airway is also not injured during the process of, say, intubation or during the process of ventilation. Again, that's where the cuff pressure management comes in very important. I hope this has been touched upon somewhere. If somebody wants to quiz me on this, we'll discuss that during our interaction. Okay. So various reasons exist as to why the trachea could be inflamed, the vocal cords could be inflamed or damaged during the process, during the whole process of mechanical ventilation. So soon post extubation, you can have somebody going into a stridor, okay, which produces an immediate reason for extubation failure. The patient gets into respiratory distress and they become anxious. It becomes a vicious cycle. Everything screws up. Okay, so to know whether the trachea is decent enough, okay, we do this thing called a cuff leak test, which is nothing but you need to deflate the test and make sure that there is enough space around the endotracheal tube cuff for air to leak out. It is not so simple as that. There are certain precautions that you would follow. So you would take care of the oral hygiene, because the moment you deflate the cuff, you could be having a whole lot of secretions trickling down. Okay, so a good oral hygiene and then suction clearance of the throat. You put the patient on volume control mode with a 500 ml tidal volume, probably for an adult patient, that is, and then you deflate the cuff and assess for the leak. So the inspiratory tidal volume will be something like 500 ml. You need to have an expiratory tidal volume which should be lesser by 20%, at least 20 to 25%. So for a 500 ml that goes inside, maybe an expired tidal volume or an exhaled tidal volume of 300 means to say that there is good amount of space around the endotracheal tube, allowing for close to 20-25% of leakage to happen. This is, this gives us a sense of security that there is no active laryngeal edema or airway edema, which could raise a risk factor for post-extubation stridor. Okay. Having said that, I'm going to give a clause there. It doesn't mean that this is foolproof. Okay. If somebody doesn't have a cuff leak, I will be very cautious. Okay, I will go back, look into what the history has been like. Has it been a difficult airway? Have we done multiple attempts at securing the airway? Has the patient been, has the patient received multiple tubes? Have we changed tubes for a couple of times? If that patient doesn't have a cuff leak, then definitely I will be worried. I will probably not extubate. I may have to consider other strategies. But if it is somebody who has a straightforward intubation done by an expert, otherwise a short course of intubation and mechanical ventilation, then it is not that you cannot extubate. You have to extubate keeping in mind the high possibility of an airway stridor. Okay, so the same thing if it is somebody with let's say a difficult airway. If it was a challenging airway to start with, definitely I would not extubate it. If it was somebody who was straightforward, not sick, easy, but there is no cuff leak for some reason, then it is still worth an extubation trial. Okay. The next thing I've written over there is the routine use of pre-extubation methylprednisolone. So globally, it is said that the incidence of stridor post-extubation is somewhere between 12 to 22%. Again, obviously, it depends depending upon the center, depending upon the kind of patients that we handle, the kind of ICU infrastructure, various things, obviously. But there is no need for a routine pre-extubation methylprednisolone therapy. However, like in one of the previous settings that I told you, no cuff leak and multiple attempts at intubation, where you strongly suspect that there could be a possibility for a laryngeal edema, you can use methylprednisolone in the dose of 20 to 40 milligrams every fourth hourly for 3 doses. So you start 12 hours before the extubation, give 3 hours at 4 hourly intervals, and probably follow up with one more dose after the extubation. So there is a role for pre-extubation methylprednisolone in those situations, right? And obviously, other risk factors for extubation failure need to be considered. If this is somebody with a pre-existing lung disease, like chronic lung disease, COPDs or ILD, if it is a very elderly person, if the person has multiple comorbidities, obviously it raises us on a frown because they could have a high chance for an extubation failure. You need to have the next strategy in mind. Like, for example, what I put up next is the role of non-invasive ventilation or nasal high flow oxygen therapy for these so-called high-risk patients or patients at high risk for extubation failure. You cannot be putting them on a tube and ventilating them forever because they have a high risk for extubation. Maybe you can switch them over to, you can extubate them and switch them over to a non-invasive ventilation or a nasal high flow oxygen therapy if it is an appropriate setting. Again, I believe that NIV and NHF have been covered at different sessions.